In endocrinology, the most commonly asked 10-mark question is hypothyroidism, followed by Graves' disease, and then the Cushing's disease, Addison's disease, and thyrotoxicosis has been asked as 10 marks question only once, but these three topics are important 5 marks question which are asked many times as 5 markers. So we are discussing under endocrinology 10 mark questions: hypothyroidism and Graves' disease, thyrotoxicosis or hyperthyroidism, thyrotoxic crisis or thyroid storm, followed by hypercalcemia, Cushing syndrome, and Addison's disease and Addison's crisis. Let's start with hypothyroidism. What is hypothyroidism? Hypothyroidism is a clinical syndrome characterized by reduced T3, T4 levels, which lead on to reduced metabolic process, impaired metabolic process, the slowing of metabolic process. This is the definition of hypothyroidism. Now, let's see the introduction for hypothyroidism. We can see hypothyroidism in children and in adults. In children, it can be in infants and children. In infants, if the infant has hypothyroidism, it can lead on to permanent mental retardation, which is called as cretinism. In the children, hypothyroidism leads on to slowing of growth and development. Why so? Because thyroid hormone is required for neuronal proliferation and synapse formation between the neurons. And also, it is required for chondrocyte proliferation and endochondral ossification, which are required for skeletal growth. To this reason, there will be slow growth and development seen in these children with hypothyroidism. In adults onset hypothyroidism, there will be generalized slowing of metabolism. That is, lipids, proteins, and carbohydrate metabolism are decreased. They are slowed down. Due to these reasons, there will be increased glycosaminoglycans in the tissues, which lead on to specific clinical manifestations. There will be reduced oxygen consumption in the tissues. There will be reduced heart rate. We'll see them one by one. What is the pathophysiology of hypothyroidism? Why we see hypothyroidism in a patient? Hypothyroidism can be primary hypothyroidism, secondary hypothyroidism, or tertiary hypothyroidism. What is this primary, secondary, and tertiary hypothyroidism? We have HPT axis, hypothalamo-pituitary thyroid axis. If there is any disease of thyroid causing hypothyroidism, it is called as primary hypothyroidism. If there is any disease of pituitary causing hypothyroidism, it is called as secondary hypothyroidism. If there is any disease of hypothalamus leading on to hypothyroidism, it is called as tertiary hypothyroidism. Now, the primary hypothyroidism is the most common form of hypothyroidism that we see in 95% of patients. The primary hypothyroidism can be subclinical, where in case of subclinical primary hypothyroidism, the TSH level will be increased with normal T3, T4 levels. Or the patient can have overt hypothyroidism, where there will be reduced T3, T4 levels causing on to clinical manifestations of hypothyroidism. What are the causes of the primary hypothyroidism? In pediatric age group, we see dysharmonogenesis due to genetic disorder called as Pendred syndrome, which is autosomal recessive, where we see goiter with sensorineural hearing loss, that is Pendred syndrome. There can be primary hypothyroidism due to autoimmune destruction of thyroid gland. The autoimmune destruction of thyroid gland can be due to Hashimoto's thyroiditis, which is the second most common cause of hypothyroidism and the most common non-iodine cause of primary hypothyroidism or hypothyroidism. Due to autoimmune attack, we also have other disease called as postpartum thyroiditis, which is a transient condition which is seen after delivery. The most common cause we already know is iodine deficiency causing hypothyroidism. We can also have other infiltrative diseases like Riedl's thyroiditis and leukemia causing primary hypothyroidism. What are the causes of secondary hypothyroidism? We know they are the diseases of pituitary gland. We can have pituitary adenoma causing hypopituitarism, leading on to reduced TSH level, which leads to reduced T3, T4 levels. We can have Sheehan syndrome, where we see hypopituitarism there itself postpartum finding, which is one of the complications of after delivery. The secondary hypoparathyroidism can be due to lymphocytic hypophysitis causing mass effect into the pituitary gland and reduce TSH secretion from the pituitary gland. What are the tertiary causes of tertiary hypothyroidism? That are the diseases affecting hypothalamus. Those are tumors, trauma, and radiation causing injury to hypothalamus gland, which causes reduced TRH, thyroid releasing hormone secretion, which leads on to reduce TSH, which leads on to reduced T3, T4 level. This is about the etiopathophysiciology seen in case of hypothyroidism. Now, what are the clinical symptoms, clinical signs that we see in case of hypothyroidism? Please note, hypothyroidism is not clinically obvious. Only the severe grade of hypothyroidism can be clinically obvious with these symptoms and signs. Most of them are not clinically obvious. They can present to you with only weight gain, tiredness, depression, cold intolerance, and also the patient can present you with carpal tunnel syndrome due to the deposition of glycosaminoglycans due to reduced activity, due to its reduced breakdown, secondary to reduced T3, T4 levels. Now, what are the head to toe manifestation seen in case of hypothyroidism? First, coming on to CNS manifestation. Due to reduced T3, T4 levels, we see depression in patients. They are depressed, not because of any life event like love failure, but because of reduced T3, T4 levels. They can have increased somnolence, increased sleepiness. Also, we have Waltman's sign as a CNS manifestation. What is this Waltman sign? When we do tendon reflex, deep tendon reflex like knee jerk, we have rapid contraction of muscles followed by rapid relaxation of muscle. If T3, T4 levels are decreased, when we do deep tendon reflex, there will be rapid contraction, but rapid contraction will be followed by delayed relaxation or slow relaxation, which is called as Waltman's sign, where there is delayed relaxation of tendon reflex. We finished with CNS manifestation. What are the manifestations that we see in face? We have hypothyroid facies, where we see periorbital puffiness due to deposition of glycosaminoglycans around the orbit. Periorbital puffiness. You can see in this patient periorbital puffiness. We can see facial pallor. Why facial pallor? Facial pallor can be due to anemia, the normocytic normochromic anemia that we see in hypothyroidism, or due to anemia, increased carotene levels due to reduced conversion of beta carotene to vitamin A. This causes facial pallor. We also see macroglossia, large tongue, due to increased deposition of glycosaminoglycans and mucopolysaccharides, which can lead on to obstructive sleep apnea syndrome. And also characteristically, we see alopecia in these patients. We know when we have alopecia, first we will do TFT. All these facial manifestations are due to increased mucopolysaccharides, increased hyaluronic acid, increased chondroitin sulfate in dermis and subcutaneous tissue. In face, when there is accumulation of these substances in subcutaneous tissue, it causes periorbital puffiness and other manifestations. If there is deposition of these substances in hands, feet, and face, in dermis of skin, we see non-pitting edema. This is all the facial manifestations that we see in these patients. You can see goiter in case of Hashimoto's thyroiditis. We see autoimmune destruction of the gland, which is one of the most common cause of hypothyroidism secondary to iodine deficiency. Following that, we'll go for CVS manifestation. We all know that T3, T4, that is thyroid hormones, are responsible for sensitivity of catecholamine receptors to the epinephrine and norepinephrine. They cause a sensitivity of it. When there is reduced T3 level, T3, T4 levels, there will be reduced sensitivity of sympathetic receptors, that is alpha and beta receptors, to norepinephrine and epinephrine, leading on to bradycardia. There can be pericardial effusion. Characteristically, we know that T3, T4 thyroid hormone is responsible for increased responsiveness of blood vessels to nitric oxide, causing vasodilation. So when T3, T4 level is decreased, there is reduced nitric oxide level activity, leading on to vasoconstriction and increased peripheral vascular resistance, leading on to increased diastolic BP or diastolic hypertension, seen in case of hypothyroidism. We saw CNS manifestation, facial manifestation, serious. Let's go on to GIT manifestations. GIT, due to reduced bowel activity, we can see constipation. Second to that, we can see reduced appetite. What are the genitourinary manifestations that we see in these patients? Those are delayed puberty. Normal thyroid hormone is required for normal growth spurt and puberty, which is seen. The thyroid level, reduced thyroid hormones will cause delayed puberty. Please note, thyroid hormone T3, T4 level decreased. When thyroid hormone is decreased or increased, it causes amenorrhea. And also in case of hypothyroidism, we can also see menorrhagia. Second to this, there can be infertility seen in these patients. These are all the clinical manifestations that we see in hypothyroid patients. Now, how do we manage these patients? Obviously, first we will do TFT, thyroid function test. And also if we do ECG, we can see bradycardia and low voltage complex. The reason for it I already mentioned. When we do TFT, first we'll look for TSH levels, thyroid stimulating hormone, TSH levels. If the TSH level is increased, this means that there is no pathology in pituitary and hypothalamus, leading on to hypothyroidism. So since there are no pathologies in pituitary and hypothyroidism, there can be increased TSH. When the T3, T4 level is decreased, the pituitary and hypothalamus is responding by increasing the production of TSH. So it should be the case of primary hypothyroidism. In primary hypothyroidism, we already saw it can be subclinical disease or overt disease. In case of subclinical disease, the T4 levels, free T4 levels will be normal. We know that. If we have overt hypothyroidism, we will see primary hypothyroidism. So then we'll estimate TPO levels, thyroid peroxidase antibodies level, which will be positive in case of Hashimoto's thyroiditis. If it is positive, we confirm that the patient has Hashimoto's thyroiditis and we'll give him levothyroxine. If it is negative, we'll search for other causes of primary hypothyroidism. And if not, we'll proceed on with levothyroxine treatment. If the patient T4 level is normal and then patient is TPO negative, we can search for alternative diagnosis and we'll keep the patient on annual follow-up. Now, let's go on to other spectrum, secondary and tertiary hypothyroidism. So we see if the pituitary disease we are suspecting, we can get to know that by other manifestations of hyperpituitarism. If we suspect, we'll measure T4 levels. If the T4 levels is normal, then no test is required. Search for alternate diagnosis. If T4 level is low, we'll evaluate for pituitary causes like pituitary adenoma or other infiltrative disease of pituitary, etc., etc. Or the patient may have euthyroid, sick euthyroid syndrome. What is this sick euthyroid syndrome? Sick euthyroid syndrome is a syndrome where the patient has reduced T3 levels with T4 reduced T3 levels, reduced T3 levels with T4 being normal or increased. Why do we see this sick euthyroid syndrome? Sick euthyroid syndrome is due to malnutrition, HIV, anorexia nervosa, and cirrhosis, causing impairment of hypothalamo-pituitary thyroid axis, which causes reduced T4 levels and manifestations. We don't usually recommend treatment in these patients of sick euthyroid syndrome. When these conditions are met, the euthyroid state will be resumed. We'll get the normal thyroid function. It can also be due to drug effect when the T4 is reduced with normal TSH. It can also be due to drug effect like lithium and amiodarone can cause reduced T3 level, T4 levels, that is hypothyroidism. Now, how do we treat these patients? These patients are treated with levothyroxine sodium. Levothyroxine sodium given as OD dose once a day. The dose is 1.6 to 2.3 microgram per kg per day. Tablet should be preferably taken in empty stomach 1 hour before breakfast. So, if the patient is elderly and has coronary artery disease, to reduce the complications of therapy, we start with minimal dose, that is 25 to 50 microgram per day. Then we can step up. After giving this therapy, we will review the patients after 4 to 6 weeks. We will check the TSH levels after 4 to 6 weeks. TSH level can be normal or increased. If it is normal, continue with the therapy lifelong. If the TSH level is increased, we'll increase the dose by 12.5 to 25 microgram. Increase the dose on top of previous dose, increase the dose by 10.5 to 25 microgram. Okay. After this, we will again reevaluate TSH levels after 6 weeks. And then we'll do dose adjustment accordingly. Please note, during pregnancy, the dose should be increased by 25 to 50% due to increased requirement of thyroid hormones during pregnancy. This is all about hypothyroidism. Let me summarize hypothyroidism. Hypothyroidism is a state where characterized by reduced T3, T4 levels. We saw the basics. In children, if they have permanent mental retardation if the infants have hypothyroidism, they will have permanent mental retardation called as cretinism. The children will have slow growth and development. The adults will have increased glycosaminoglycans, chondroitin sulfate, and hyaluronic acid, which leads on to deposition of these substances, leading on to mixed edema or the non-pitting edema in extremities. What is the etiopathophysiciology? We saw three types: primary hypothyroidism, secondary hypothyroidism, tertiary hypothyroidism. Primary hypothyroidism, thyroid is involved. It can be due to dysharmonogenesis, isometric thyroiditis, postpartum thyroiditis, reduced iodine deficiency, and infiltrative diseases like renal thyroiditis and leukemia. The secondary hypothyroidism due to pituitary causes can be due to pituitary adenoma, Sheehan syndrome, and lymphocytic hypophysitis. The tertiary hypothyroidism involving hypothalamus can be due to tumors, trauma, and radiation, leading on to clinical manifestations. The clinical manifestation not so obvious. The patient can present you with weight gain, tiredness, depression, carpal tunnel syndrome, and cold intolerance. The head to toe manifestations are the CNS manifestation, Waltman's sign, increased somnolence, depression. The facial manifestations are alopecia, periorbital puffiness, facial pallor, and macroglossia. Serious manifestations are bradycardia, diastolic BP, increased diastolic hypertension, pericardial effusion. GIT manifestations are constipation. Genitourinary manifestations are delayed puberty, neuralgia, amenorrhea, and infertility. The management of these patients are investigations will do TFT and ECG. And we saw in great detail about TFT. Following that, we'll treat the patient with OD dose 1.6 to 2.3 microgram per kg per day, preferably taken in empty stomach 1 hour before the breakfast. By this, we are ending the discussion on hypothyroidism. Hyperthyroidism, we have three different terms. Please be clear with these three different terms. That is hyperthyroxinemia, thyrotoxicosis, and hyperthyroidism. All these three terms mean different. Hyperthyroxinemia is a broad term where there is increase in total T3 T4. That is, increase in total T3 T4 is equal to free T3 T4 in plasma plus the T3 T4 which are bound to globulin, thyroid hormone binding globulin. T3 T4 bound to thyroid hormone binding globulin. If there is increase in total T3 T4, it is called as hyperthyroxinemia. Hyperthyroxinemia, we saw it can be due to increase in free T3 T4 or due to increase in bound T3 T4. If hyperthyroxinemia is due to increase in free T3 T4 in plasma, it is called as thyrotoxicosis. If hyperthyroxinemia is due to increase in thyroid hormone binding globulin, the globulin bound T3 T4, it is called as euthyroid hyperthyroxinemia, which is usually seen in pregnancy and estrogen therapy due to increased thyroid binding globulin levels. Now, in thyrotoxicosis, we know that there is increase in free T3 T4. The increase in free T3 T4 can be due to diseases in thyroid, can be due to diseases in pituitary gland, can be due to ectopic secretion of thyroid hormones. In thyrotoxicosis, the causes related to thyroid gland causing increase in free T3 T4 is called as hyperthyroidism. Now, what are those causes? Thyroid causes causing hyperthyroidism. Those are Graves' disease, toxic nodule, and toxic multinodular goiter. These are the three diseases of thyroid causing increase in free T3 T4 causing hyperthyroidism. We can have increase in free T3 T4 due to pituitary causes like pituitary adenoma secreting increased TCH causing increased TSH causing increased T3 T4. We can have ectopic secretion of T3 T4, that is from ovarian tumor called as tumor ovary, causing the manifestations of thyrotoxicosis. Or there can be increased release of thyroid hormones without any disease due to intake of amiodarone drug, which is an anti-arrhythmic drug, or also due the increased release of thyroid hormones can also be due to subacute thyroiditis. The inflammation and destruction of thyroid tissue causes the release of T3 T4 into the system, causing the manifestations of thyrotoxicosis. This is the etiopathophysiciology of hyperthyroxanemia. Now, one of the most important cause of thyrotoxicosis and hyperthyroidism is Graves' disease. 75% of thyrotoxicosis are due to Graves' disease. Very important topic. Graves' disease is very important topic of discussion. What is Graves' disease? Graves' disease is an autoimmune condition characterized by one or more of these following features. That is features of thyrotoxicosis or goiter or orbitopathy, thyroid orbitopathy or thyroid dermopathy. What are these? We'll see shortly. Before that, let's see etiopathophysiciology of Graves' disease. The risk factors for Graves' disease are: we see peak incidence of Graves' disease in 20 to 40 years of age. Graves' disease is most commonly seen in females than males. Graves' disease patients, we know it's an autoimmune conditions. They have HLA DR2 and CTLA4 mutations. Smoking has been associated with Graves' disease. Now, what are the autoantibodies produced in Graves' disease? The autoantibodies are thyroid stimulating hormone receptor antibody. Antithyroid receptor stimulating hormone antibody is seen in case of 80 to 95% of patients. So these antibodies will go and stimulate the TSH receptors on the follicular cells of thyroid, causing increased production of T3 T4 and also enlargement of thyroid gland due to thyroid hyperplasia. These antibodies, that is anti-TSH receptor antibodies, will stimulate the T cells of the body. Along with the stimulation of T cells, which causes inflammatory destruction of thyroid gland, it stimulates the production of glycosaminoglycans, and also it stimulates the fibroblast. Due to these three reasons, we see thyroid ophthalmopathy, thyroid dermatopathy, thyroid acropathy, which are the characteristic manifestations which are only seen in case of Graves' disease. In other diseases causing thyrotoxicosis, we don't see these manifestations. Only it is specific to Graves' disease. In 80 to 95% of patients, we see anti-thyroid stimulating hormone receptor antibody. In remaining patients, we can see anti-thyroglobulin antibody and anti-thyroid peroxidase antibody. This is about the etiopathophysiciology of Graves' disease. What are the clinical manifestations? We have characteristic clinical manifestations of Graves' disease and also the manifestations of thyrotoxicosis that we see in Graves' disease. What are the characteristic clinical manifestations only seen in Graves' disease? Those are thyroid ophthalmopathy, thyroid dermopathy, and thyroid acropathy. What are the manifestations seen in thyroid ophthalmopathy? We see many signs. Out of those, I have taken only important 4 signs. We have Dalrymple sign, that is upper eyelid retraction. We have proptosis in case of thyroid ophthalmopathy due to inflammatory damage, and increased activity of fibroblasts and accumulation of glycosaminoglycans. We see proptosis in case of Graves' disease, which is leading on to upper lid retraction, which is called as Dalrymple sign. It also leads on to staring look, called as Cocker's sign. It also leads on to lid lag, called as von Graeff's sign. And due to proptosis, when the patient is shown the near object, will be unable to converge, which is a normal reflex which is seen in normal individuals. Normal accommodation reflex is absent in case of thyroid ophthalmopathy. That is called as Mobius sign, where there is no convergence on seeing near objects. What is thyroid dermopathy? Thyroid dermopathy is bilateral, asymmetric, non-pitting induration of skin, called as pretibial myxedema. What is thyroid acropathy? Thyroid acropathy is digital clubbing and swelling of fingers and toes. The reasons of which we saw: digital clubbing with swelling of fingers and toes. These are all the characteristic clinical manifestations that we see in Graves' disease. What are the other clinical manifestations that we see in case of Graves' disease? There is manifestations of thyrotoxicosis. From head to toe, we have. Please note, the manifestations that I am mentioning now are seen in other causes of thyrotoxic also, and also they are seen in Graves' disease. Those are the CNS manifestations. We see irritability, anxiety, nervousness, and fine tremors. The reason for it we know. The anxiety, nervousness due to increased sympathetic activity. I already mentioned that thyroid hormone is responsible for sensitivity of the norepinephrine and epinephrine to the catecholamine receptors. Due to that, the patient can have anxiety and nervousness. Coming on to skin manifestations, the patient will have, due to increased sympathetic activity, the warm skin and increased sweating and palmar erythema. What are the CVS manifestations that we see in these patients? Those are sinus tachycardia due to increased sympathetic activity, which may lead on to atrial fibrillation. In those patients, we can see palpitation. And also on CVS examination, we'll see reduced diastolic BP. The reason of which we already know. I mentioned in hypothyroidism, how diastolic BP is associated with T3, T4 levels. What are the RS manifestation? Respiratory system. There can be increased ventilation, and the goiter that we can see in Graves' disease can obstruct the trachea, causing tracheal obstruction and breathlessness. What are the hematological manifestations that we see in these patients? We have other autoimmune conditions like immune thrombocytopenic purpura and pernicious anemia in these patients. And also both in hypothyroidism and hyperthyroidism, we can see normocytic, normochromic anemia. The genitourinary manifestations are oligomenorrhea and infertility and nocturia. We can see oligomenorrhea and amenorrhea in both hyperthyroid and hypothyroid patients. Very, very important. This is all about the clinical manifestations that we see in thyrotoxicosis. Now, how do we treat these patients? How do we manage these patients? First, investigations. When we do thyroid function test, there will be reduced TSH levels with increase in T3, T4 levels. When we do thyroid scintigraphy, there is increased uptake of iodine 131. And also when we do estimation of ELISA and other technique, we can detect anti-thyroid stimulating receptor antibodies, thereby confirming Graves' disease. To treat this patient, we know there is sympathetic overactivity in case of Graves' disease, so we give propranolol 40 mg 6th hourly. It will cause immediate relief of anxiety, palpitation, and increased basal body. Palpitation and anxiety will be relieved instantly. due to propranolol treatment. Now, we saw there is increased T3 T4 levels due to stimulation of TSH receptors by these antibodies. So, how to reduce synthesis of these hormones? Temporarily, we reduce the synthesis of these hormones by giving anti-thyroid drugs like methimazole and carbimazole. Carbimazole dose is 5 mg given thrice a day. And following this, we'll give anti-thyroid therapy for 1 to 2 years where we get remissions. If we don't do this, it can lead on to dreaded conditions like thyroid crisis, which we'll discuss shortly. After 1 to 2 years of remission, we carry out definitive treatment, that is radioiodine ablation or subtotal thyroidectomy. In subtotal thyroidectomy, we are excising the thyroid gland partially. In radioiodine ablation, the radioiodine ablation we prefer only if the patient is more than 40 years or has short lifespan due to other diseases, where we give iodine 131 large doses, which causes destruction of thyroid gland. Thereby, when the thyroid gland is destroyed, there will be reduced T3 T4 levels. What are the complications associated with radioiodine ablation? Those are hypothyroidism and infertility. This is all about hyperthyroidism. To summarize, we saw hyperthyroxinemia where there is increase in total T3T4. We can have euthyrotoxicosis and euthyroid hyperthyrotoxinemia in case of hyperthyrotoxinemia. In thyrotoxicosis, there is increased T3T4, free T3T4 levels. If they are due to thyroid causes, it is called as hyperthyroidism. If it's due to pituitary causes, the pituitary causes can be pituitary adenoma and others. There can be ectopic secretion of thyroid hormones. It's called as tumor ovary or tumor which can secrete T3 T4. The causes of hyperthyroidism are Graves' disease, toxic nodule, toxic multinodular goiter. Then we saw Graves' disease in great detail. The etiopathophysiciology, risk factors, and antibodies. Anti-TSH receptor antibodies, which is seen in 80 to 95% of patients, which stimulate TSH receptors, causing increase in T3 T4 levels and enlargement of thyroid gland. And also, these antibodies will cause stimulation of T cells, like production of glycosaminoglycans, and they will stimulate fibroblasts, which causes three characteristic findings that are thyroid ophthalmopathy, thyroid dermopathy, and thyroid acropathy. The characteristic clinical manifestations that we see only in Graves' disease are thyroid ophthalmopathy, thyroid dermopathy, and thyroid acropathy. The manifestations of thyrotoxicosis are CNS manifestations, CVS, GIT, and genitourinary and hematological. CNS are irritability, anxiety, nervousness. CVS, sinus tachycardia, atrial fibrillation, reduced diastolic BP. RS, increased ventilation and obstruction of trachea. The hematological, we can see normocytic, normochromic anemia, immune thrombocytic, purpura, and pernicious anemia. Genitourinary manifestations, we can see oligomenorrhea, infertility, and nocturia. Then we saw how to manage these patients. We do TFT, decrease TSH level, increase T3 T4 level, scintigraphy, increase uptake. And also we can detect TSH receptor antibody by doing ELISA and other techniques. We'll treat the patients by giving beta blockers and the treatment which is aimed to reduce the synthesis of this secretion of T3 T4. The beta blockers propranolol will give 40 mg 6-hourly, antithyroid drugs methimazole and carbimazole given at a dose of 5 mg TDS. After remission, 1 to 2 years, we'll give definitive treatment, that is subtotal thyroidectomy. And if the patient is more than 40 years or a short lifespan, we can try radioiodine ablation. This is all about hyperthyroxinemia. See, one of the acute emergency seen in case of hyperthyroidism, that is thyroid storm or thyrotoxic crisis. It is an acute emergency. It's a complication of thyrotoxicosis associated with 10 to 30% mortality. What is the etiopathophysiciology of this condition? The long-standing hyperthyroidism, which is not treated, untreated, long-standing hyperthyroidism, which increased T3 T4 levels, along with acute event leads on to thyroid storm. Now, what are those acute events leading on to thyroid storm or thyrotoxic crisis? Those are severe infections like sepsis, and the patient can develop thyroid storm following subtotal thyroidectomy and radiotherapy with iodine 131. If the patient is ill prepared before the surgery, there can be transient increase in T3 T4 leading on to thyroid storm in these patients. Diabetes ketoacidosis, myocardial infarction, and major trauma are other events which are associated with thyroid storm. How do these events cause thyroid storm? These events result in increased secretion of T3 T4, or there can be increased responsiveness to catecholamines, increased response to T3 T4, already increased T3 T4 levels to cells may have increased response to all already elevated T3 T4 levels. Three mechanisms causes thyroid storm. Please note, when we measure T3 T4 levels, it can be acutely increased in if it is due to increased secretion, or the increased T3 T4 level can be similar to that of hyperthyroid patients if the thyrotoxic storm is due to these two reasons. Now, what are the clinical manifestations seen in thyrotoxic crisis? The clinical manifestations are due to hypermetabolism and increased adrenergic response. No, it is physiology. We already discussed two to three times why increased adrenergic response. These things will lead on to hyperpyrexia, that is the temperature between 104 to 106 degree Fahrenheit with flushing and sweating. There can be marked tachycardia due to increased sympathetic activity. The heart rate can be more than 140 beats per minute. The patient can have atrial fibrillation. Following that, he may go on to develop hypotension. The CNS manifestations, the patient can present to you with psychosis and delirium. The GIT manifestations are diarrhea and vomiting due to increased bowel activity. Now, how do we manage these patients with thyrotoxicosis or thyroid storm? The investigations will see reduced TSH level, increased T3 T4 levels, no brainer. And also we can see hyperglycemia due to increased catecholamine responsiveness. How to treat these patients? We give propyl thiouracil 1000 mg stat followed by 250 mg 4th hourly. Also, we can give propranolol 60 mg 4th hourly to fight back the increased sympathetic activity. The steroid use in these patients has seen to be helpful. To summarize, thyrotoxic crisis is an acute emergency in case of thyrotoxicosis associated with 10 to 30% mortality, where the acute events like severe infections, subtotal thyroidectomy and radiotherapy in an ill-prepared patients, diabetic ketoacidosis, MI, and major trauma patients leads on to thyroid toxicosis due to these three mechanisms. The clinical manifestations that we see is hyperpyrexia, marked tachycardia, atrial fibrillation, hypotension, psychosis, delirium, diarrhea, and vomiting. The investigations findings we saw reduced TSH, increased T3 T4 levels, hyperglycemia. The treatment is propyl thiouracil 1000 mg stat followed by 250 mg 4th hourly, propranolol 60 mg 4th hourly, and steroids. This is all about thyroid crisis. Thank you for thyroid storm or thyrotoxic crisis. Thank you for listening.